mechanism of health financing. So the again this primarily talks about the this primarily talks about the of sources and how do they work, and then we will talk about these sources separately. So one is general revenue from earmarked taxes or earmarked taxes, whatever, which comes from the government. The second one is social insurance contribution. The third one is private insurance program. The fourth one can be community financing. It can be an insurance, it cannot be an insurance. The fifth one is direct out-of-pocket expenditure. So each of it has a distribution mechanism, and these financial burdens and benefits, they distribute differently. The social insurance contribution, their target population is different from private insurance programs or from any particular schemes funded by the earmarked taxes or the direct out of pocket expenditure. The amount of direct out of pocket expenditure and to whom these expenditures are being made, so they are very very different from population to population, from across different socioeconomic backgrounds, and each method affects the health seeking behavior differently. It affects the implication on the financial status of that household differently, and it has different implication thus to the financial protection of the overall society and the individual, of course. Therefore, if I try to discuss about these mechanisms one by one, what happens? The first one is of course the government budgeting, which comes from the general revenue of the government, that is the government's income, general revenue of the government through earmarked taxes. So general revenue or earmarked taxes. So this is the most traditional way of financing, if not out of pocket expenditure. Of course the government takes care of the people's individuals health and they pay for that. So government has its own health system mechanism, or the primary I mean public sector takes the major responsibility of people's health. Then this is the most traditional way of, again, if not the out-of-pocket expenditure taken into consideration, and it finances a major proportion of the healthcare. Especially for the poor people. Because they, whatever they, will happen, if they can afford, they will come to the government hospital, or if there is a some critical treatment is required, they will come to a government hospital. Otherwise, if there is no government institution, let's say primary health center, community health center, they can go for a traditional healer or some quacks nearby. Even now a lot of a high percentage of birth takes place at so no institutional delivery, so it takes place at home, or some untrained die, or somebody in around maybe not less than 40% in most of the sub-Saharan African countries. The scenario has improved a lot in India in last 1 or 2 decades. In Bangladesh, in Sri Lanka, they have done exceptionally well, but but still in these developing countries, we for any major health treatment we rely upon the government institutions. So the second one can be social insurance or social health insurance. It's compulsory, as mentioned, it is compulsory because most often it is funded by the government, and it's not for everyone. A eligible group of people which government thinks need to be covered, or which a particular organization thinks need to be covered, eligible group of people, and it follows a specific pattern of contribution. Say under CGHS, they pay a certain section of the salary, and the contribution rate is higher, even though the coverage is absolutely same for a top level officer to the group D staff. The the coverage is absolutely same, the benefits are absolutely same, but the contribution which comes from different, the lower level employees, they will have a lower share of their salary going to the CGHS, where the top level managers, they will have to pay a larger section of their salary, so their contribution is more. So and it's not similar everywhere. Say for a particular scheme, ESIS, maybe those who earn something close to rupees 137 per day, for them there is no contribution. If anybody earns more than 137 per day, they have to pay 1.75% towards this ESIS scheme. So it's like that. So there is a specific pattern of contribution under each schemes, under each social health insurance program, and this the benefits, the premiums, coverages, all are decided through legislations, because it's often by the government. So it has to be passed as a bill, so it comes through the legislation as a bill, and it follows a formal political process to get this particular legislation passed, or particular health scheme passed. So these two are broadly the government related health financing mechanisms, and then the major private health financing formal mechanism is private insurance. Private insurance. Now, what happens in private insurance? A private contract, a private organization offers a contract to an individual or a group of individuals. And this contract talks about what should be the premium, how much that individual has to pay, if there is a claim under that insurance, when the patient or somebody under that particular insurance is ill, then how much the insurance company is going to pay, how much the patient is going to pay, that is the known as indemnity and co-payment respectively. If the insurance company is paying, that is indemnity; if the patient is paying, that is co-payment, and together it is 100% the total payment. And for how long it is covered, which are the hospitals that they can go, which are empaneled under the schemes, where and which are the diseases, of course, are covered, which are the whether there is health checkup, whether this cardiovascular disease, whether dengue is covered, and all these things. Yeah, so that is basically a private health insurance contract, and it is basically marketed either by non-profit, if it is an NGO based, or a profit making insurance company. Yes, Finally, here it's as voluntary, the consumers make their own choices, looking at their offers and matching them with their individual preference. Yeah, so it's very voluntary. So this talks about voluntary payment. Yes, that the consumers make their own choices based on their preference. If you give me a coverage of I am 50 years old, I have not married, and you say that I will cover the pregnancy benefit for your family, it hardly matters. Yeah, so I will not pay unnecessarily for those benefits, which probably, so I will like to customize it, or I will like to, there are plenty of insurance companies, so I will like to get that one which meets my requirement, and where they don't really ask me to charge for the unnecessary benefits which I don't require. But what happens is there is always, the problem, as it is, they are, I said here, it's an individual or a group basis. So either they will approach the patients, I mean the individual customers, or they will approach they will approach the organizations where they can avail a group of individuals together under a particular socio-economic background, or professional background, and which actually is giving them a large business at one point, or at one time, with the lesser effort. So it can be either in the individual level or the group level, and then the policies really change whether it is group level or individual level. The bargaining takes place, so that can be dealt with in a different session. Whereas in this private insurance, there are two problems they face. One is moral hazard, that even if I don't require a particular hospitalization, I still go, so that is moral hazard under private insurance schemes, because my private insurer will pay for me, so I don't really mind. And that's where these private insurance companies are making losses, because this unavoidable hospitalization which the consumer or the patient has to bear by their own, so they are not doing that. They are passing the cost upon the health insurance companies. They still can do that, because they say that we are paying for so many years, and this is the first time I am availing, or something like that. They still have a justification, where the hospitals play this game towards their own benefit, that not all, but of course few. So they allure the patients, that because it also generates one night extra stay, or one even if unnecessarily, but one day stay in a hospital will give them will occupy a bed for them, and they can charge a higher bill. So that is one moral hazard. And another one is adverse selection, because once they go for this, it's a in a country like India, where the market is developing, these private insurance companies are really competing with each other. It's a strong competition, and everybody tries to get their get or sell their insurance to the healthy people, because in that case they will earn money, because they will get the premium, but they don't have to pay anything. But in that case, maybe many of their potential customers, they are lying that they don't have any physical adversities, they have followed a good healthy behavior. So that is why. And if they are lying, then the even if the health insurance company do not expect that these people will fall sick, they fall sick, and then the private health insurance company has to make an unexpected payment. So they may make losses because of these two causes, moral hazard and private health insurances. And The third one is that under group insurances, as I said, it's basically estimated based on the characteristics of a particular group, and they also look at several they consider several things, and that also happens in for an individual insurance, that they will look at age, gender, socioeconomic background, their health profile, and all these things before they sell the insurance, because based on those parameters they decide what will be the premium for that particular individual. The next one is that community based financing. So in community based financing, it basically refers to a particular community. They all form a network and then they pool money. So it's a risk pooling within a community. Risk pooling within a community. Now that community can be, say, for those who tie beads, they have a high chance to generate infections, like say lung infections or respiratory problems. So a particular NGO comes forward or a particular organization comes forward, they try to convince everybody, bring everybody together, and then try to sell the or try to form a health insurance mechanism, and where all these the employees or those who are associated with this industry or are interested to join this community health financing program, they contribute a very low amount of the money, and then they pool that money, and whenever anybody of that community falls sick, they can utilize that money. But then this community based financing is not a very easy task to operate with, because it requires a lot of technical strength, because they are dealing with people who are poor, who often can fail to make the payments or their contributions. Technical strength and institutional capacity. They are also unaware of these the health hazards, its implications, and all this. So it's mobilizing them, continuing with the scheme is really challenging, and to continue years after years to meet with any particular adverse situation. So they may also require financial protection from other groups. Political supports or association with influential people. So you can understand that with this they are actually trying to strengthen their network, mobility or diversity of funds from other sources. So if they are working on this agricultural risk protection as well as health risk protection, the same organization, if there is a health calamity, they can probably pool the fund from this agricultural risk protection fund towards this to meet this health calamity. With this political support, technical strength, they can, if there is a problem, they can probably convince the people by the influences of these political leaders, or they can use their influences to gain or to ambulance, or to mobilize a particular private clinic, or to arrange health camps and all these things. And this is very, very important. And finally, this community based financing organizers or administrators should be able to adapt with the changing environment. So whichever the particular condition, the scenario lies, they should have to adapt themselves and act quickly, because these people, they are mostly illiterate, or with having low education, low awareness, may often fail to understand this particular necessities and these interventions and the implications of these interventions. So they may drop out very often. So it is very important that they adapt with the changing environment, to the perception of the people, if the people are migrating or changing their job. So what should be again the risks, the transiting risks, so everything has to be understood. Or if there is a kind of the change in the political environment over there, then how to manage with that. So this community health financing administrators or the organizers have to really be connected strongly with the grassroots. The last one is the direct out-of-pocket expenditure. Direct out-of-pocket expenditure. So this is the out-of-pocket expenditure which a household directly pays from their pocket. It can be cash, it can be kind. To meet their treatment costs, and they pay it to the healthcare providers. So generally, if it is known as user fee, that means they are paying to the government institutes and all. But then there have been debates that whether it is right to keep some user fee in government institutes, but but the user fees are often very, very nominal. It's a very low amount. But then it has been argued that okay, user fee is required, that generates the accountability among the patients, as well as it generates some, even if it's a very small fund, but of course generates some fund which can be utilized towards the development of that facility. So the user fees is, even though it's debated, but it's still there. So this, if I go to a government hospital, I need to get a ticket, 20 rupees or something like that. That can be called as a user fee. And however, the major objections raised in terms of user fee is equity. That there are many people who could probably afford a higher payment, but they still go to those hospitals which are meant for the poor people, and then get the treatment paying 20 rupees only, and then that increases the number of the patients in a particular hospital, or the care seekers, and which delays the entire process. And who actually lose the most? The ones who have come from a faraway place, the ones who is losing money by losing a day, and being more impoverished. So the major debate, or the major contention raised, was in terms of equity, in terms of user fee. But at the same time, when it is towards the private clinics, hospitals, then nothing can be done, because that has a question in terms of either accessibility of the government health facilities, or the quality has been under question of the government health facilities. So this out-of-pocket expenditure from this individual part has basically been more, the percentage share of the out-of-pocket expenditure has mostly been out of these private healthcare facilities in most of these developing countries. So and that is why out-of-pocket expenditure has remained as a very, very major indicator of the status of the healthcare system in a particular developing country, or the development in terms of health. So thank you very much. You can access this data again through several websites, as well as the main one can be World Bank, which gives a basic idea. And otherwise, I will ask you can also go across the schemes, so that gives you idea. There are schemes like community health insurance, like say Accord and all. So there are plenty of community health insurance schemes, so social health insurance schemes for the government. The budgeting, you can go through the budget documents in terms of the health aspects, so, and which gives you a broad idea about the health financing in any country or in India. Thank you.